forward. So welcome everyone to our April session with our Big Heart seminar. My name is Jen Balkas. I use she, her pronouns, and I'm privileged to have you all in this space and to hear from our guest speaker today. So before we get started, we just want to take a moment to acknowledge that at the UW, we learn, teach, live on or near the ancestral homelands of the Coast Salish peoples, whose ancestors have resided here since time immemorial. The UW's Seattle campus is situated on the traditional territory of the Duwamish people and the Coast Salish peoples and many other indigenous peoples that continue to thrive in these lands alive and strong. And that's where we're coming, both Marcus and I are coming from today as we host this session. For those of you, if this is your first time attending a Big Heart session, we want to just orient you to what the Big Heart program is. It is a training program that's really geared towards undergraduate and graduate Indigenous scholars who are interested in learning more about HIV research. It's not limited to institutions, so we welcome folks across the country who are interested in learning more. We have opportunities for meetings and mentorship with established Indigenous HIV researchers that are working across the field of HIV science. We have been engaging and working with folks on potential internships and job opportunities in HIV science. And for our scholars that attend multiple sessions, we have additional sort of mentorship and training opportunities, including having the opportunity to attend the annual Principles of STI and HIV Research and Public Health Practice course that's hosted by the UW, but it includes people working across HIV and STIs all over the world. So if this is of interest, we encourage you to look for more information on our website, which is listed on the slide below. We are kind of nearing the end of our sessions for this academic year. We're excited, in addition to the session, which I'll be introducing our speaker in just a moment, want to highlight two more sessions that are coming up in May. One is our Big Heart Mentoring the Mentor session. So this is the third installment of three different panels we've hosted, where we are in this session, we're going to be hearing from Dr. Angelique Day and Dr. Christopher Kemp, two individuals who are both earlier in their career and just starting in both HIV and sexual health research. And they're going to be sharing on their experiences to date so far and what's been helpful in sort of helping to get to this point and other lessons learned from them. So that's really exciting and will be happening next week. And in addition, we'll have another speaker at the end of May 31st. This is actually going to be hybrid and in person. We're excited to have Harlan Pruden joining us, coming down from British Columbia, who's going to be talking about relational accountability and being good relations, two-spirit Indigenous health research as a site of reconciliation. So lots happening in the next month. But for today, we're really excited to have Dr. Crystal Lee here from the University of New Mexico, who is a former HART fellow and has lots of connections with us here at the University of Washington, and is going to be talking about examining knowledge and attitudes towards pre-exposure prophylaxis among Native American college students. So welcome, Dr. Lee. I'm going to stop sharing so we can turn it over to you, and we're just delighted to have you in this virtual space today. So over to you.
Awesome. Thank you for having me speak today. Welcome, everyone, and thank you for taking time out of your hugely busy schedules to hear some of my research outcomes. I'll go ahead and introduce myself properly, and also I hate just being a one-sided dialogue. So please, if you have any questions, feel free to ask, and I'll do my best to answer them as needed. However, I did work with a great team, and so some of the questions I may have to direct to our other teammates and get back to you. So just to give you a more detailed response if I don't know the answer wholeheartedly. My name is Dr. Crystal Lee. I am an enrolled member of the Dene Nation, otherwise known as the Navajo Nation. I was born and raised on my tribal reservation. My tribal clans are Nato Dene Etachin Nishle, Na Nesh Eje Tambahan Bashichin, Senjikina Dashiche, Kinslajin Dashanale. So With that, I was always happy to help our communities find out more information so we can address a lot of the health disparities that we coexist with on our on and within our communities. So my talk today is centered around examining HIV biomedical prevention strategies among Native American college students. If we go to the next slide, I know a lot of us are engaged in HIV and or sexual health related work. So a few things about understanding what is how to a lot of gap in our understanding is even pure perceptions, pure knowledge, pure information on how much do we from a community framework, a community lens, how much do we really know about HIV? Data is oftentimes limited in our communities. So what are the actual numbers of our community members being diagnosed with the HIV? But due to current statistics, we know it's relatively small, but we're also acknowledging and cognizant of limited data and or lack of data that we have within our communities. But we do know that we are definitely higher risk than the non-Hispanic white populations. In comparison, when we look at Native males versus white males, the comparison is 16.2 with Native males and 9.6 with white males. And in most cases, it is contributed with identified male-to-male sexual contact. And the rate for females is lower, but for Native females, we're still significantly higher. Within our current statistics, those that identify as LGBTQI plus haven't as and also identify as male, there's also an increased risk where Native men accounted for 81% of all diagnoses compared to Native women, whom accounted for 18% of diagnoses. There's a few challenges for understanding and addressing HIV within our communities. A lot of people are hesitant or maybe hesitant to utilize the Indian Health Service to go get preventative testing and or to know their status and or to receive health care because of confidentiality reasons within our community that are located in remote and rural populations. Because when we looked at stigma or perception of stereotypes, a lot of our friends and our family work at these clinics or hospitals. And I know I myself as a community member, I know these clinicians and everyone that's within these healthcare systems. It would be challenging for even myself to go in and talk to my fellow community members and say, hey, I want to go get tested and or I want to receive care for sexual health. So I can identify what these challenges firsthand as the reluctancy to seek help to our providers who are part of our family and our community. And of course, underreporting and lack of health care, statistical surveillance in general is challenging. But then we're talking about where HIV is probably harder to receive testing and surveillance and monitoring versus if you have been diagnosed with maybe a heart condition, a more a chronic disease that still doesn't have those stigmas attached to it. So now we're getting into more of what do we know about Native youth and the knowledge and attitudes and behaviors of Native youth. And more importantly, we know that there's new science and um, new pills that can be taken to assist with preventing HIV transmission, which is PrEP and PEP. And how do our Native youth inquire about these questions? And then also, how do our social and our cultural experiences, perceptions, and interactions affect our community members with seeking help or knowledge in understanding these HIV prevention options? So I believe we did a novel study. To my knowledge, after looking at a lot of the scientific um, journal articles that are out there, not a lot that I found have been centered around basic preliminary knowledge about what Native college students from across the country, what are their knowledge and attitudes regarding HIV, PrEP and PEP. And so sorry, I'm under methods. I'm horrible. I'm horrible at assisting with informing where I'm at within the slide. So I'm on methods. Thank you. So regarding these HIV pills that are used for preventative purposes, we did an online survey that had 90 items on this survey, and most of the items on there were Likert scaled measurement systems. What we did to even produce such a survey was we acquired a review board, community experts that are Native and that have been working with tribal communities nationwide, and the area of knowledge and expertise in regards to HIV and with tribes were quite high in their experiences. So we secured a committee, if you will, to help us amend questions and or create questions that were part of this 90 item survey. And we went through a series of meetings of adapting these questions and or creating these questions that were culturally responsive to what we wanted our outcomes to be, our knowledge base. And so a lot of our questions were focused on HIV and HIV preventative pills. And within that framework, it took us about probably a good year to derive these questions with a lot of back and forth. And we targeted Native students who were enrolled tribal members, who were 18 and older, and who are currently attending any type of post-secondary education, whether anywhere from vocational school to junior college to a university institution. Now to results. A part of our methods that was not on the slide was these surveys were all conducted via online, and we work with a community-based partner, which is a nonprofit organization called United Natives. I'm actually founder of United Natives, and I'm also CEO of United Natives. So it was really easy for me to work with myself in that capacity as a community-based partner. And luckily, our nonprofit does have a lot of Native youth interns who are in college. So a big win of a part of our study was utilizing our interns to disseminate this online survey through social media platforms, through our nonprofit website, and then also to a lot of their internal networks who were also Native college students throughout the country to help us disseminate the survey. And within our methodology of the dissemination of the survey, we had 304 completed surveys done within 14 days time. And so that all of our surveys were completed in 14 days, which was amazing. And also successfully completed. We did give out $25 e-gift cards through Amazon. So each of the college students received an e-gift card through their emails. How we focus on Native college students specifically to ensure that they were in college is for them to utilize our survey. They had to enter their institutional email that had their academic affiliation email address. So we did not use a general email, for example, like a Gmail or a Yahoo. They all had to be university based. And so that's how we ensured that they were most likely college students. And so, yes, Michael had a question.
Hi, I was just wondering, like, how did you reach those targeted populations? Like, in other words, what was your outreach method to get them to know about the survey that they could take it?
Yes, we partnered with a community-based nonprofit, i.e., which is mine, and we used a lot of social media, especially Instagram. Instagram and Facebook were our top two
Great.
platforms that we used. And again, we used Native college students, and some of the Native college students that we use are quote unquote Insta famous in
Mhm.
Indian country.
Great,
So they have quite a bit of following,
great.
thousands of followers on some of, and so that just helps spread the word very quickly. And then we also did some outreach to some local and national universities. We just put the flyers, gave them to different Native American student associations as well. But primarily it was through social media that we had the most success.
That's great. I just was very curious when you said you had most of them done in 14 days. I was like,
All
there
of them. Yep, all of them done in 14.
yeah, right. That's just amazing, and that was mostly through your influencers on social media that could augment your message and get it out to the right people. That's awesome.
Yeah.
Congratulations.
And then our ties to, of course, the nonprofit, because
Right.
my nonprofit does a lot of community-based work.
Mhm.
And so we're pretty well known throughout Indian country about a lot of the community work that we do.
Beautiful. Thank you.
You're welcome. So we got a wide range of responses. Not only did we get 304 successful completion of surveys, but the surveys indicated that more than 100 different tribes were represented from each region of the US, which is inclusive of Alaska, the Alaska Native communities. And our medium age range was 22.5 years, but the reach was anywhere from 18 to 57 years old. We had higher percentage of males versus females, and we had a higher percentage of those who identify as straight. And within the LGBTQI plus community, here we have 16% who identify as bisexual, 5% who identify as gay or lesbian, and 1% who identify as two-spirit. or 1% as other. It's I think where we are now in terms of census demographics, we know that Native people predominantly live off reservation and more in urban communities, which is reflective of our demographics here. A little bit differently. So 55% indicated they grew up off the reservation, whereas almost comparable 45 indicated they grew up on the reservation. So there's almost an equal amount of a distribution of those that are reservation based and or those that are off reservation based. The role of culture and health was a little bit different for physical health versus mental health, in the aspect of cultural practices, which was important because when we were constructing the survey, we wanted to know other non-Western practices of helping with health information and or receiving healthcare. So we did include cultural practices such as going to go see a medicine man, ceremonies, anything that is related to cultural practices that may help to assist with positively impacting physical health and or their mental health. And so that was an important piece that these findings were here, that a lot of our Native people still want a form of healthcare to be integrative of their cultural connection. Also that the importance of tribal identity, culture, and language, that almost 3/4 of our participants indicate that culture is important. 72% indicate that tribe is important, and also 68% definitely indicate that tribal language is important. So despite the differences of reservation versus non-reservation, it's clearly pronounced that culture and tribe and tribal language and engaging in cultural practices as a form of their health and healing is highly important, and geographic differences does not account for the importance. Yes, Michael.
Hi, I just wanted to, since you were talking about this, I just saw Connie's question in the chat, and I really was interested in the same things as to like the differences when people define themselves as two-spirit versus gay or bisexual, and how that would be differentiated, or at least how you think people may have differentiated that when they answered that for you. And if you could look at the, give us some more comment on that, that would be great.
It's really so when we were coming up with how people may self-identify with their sexual orientation, we did put a list of one or more of how they might self-identify, but it was hard for us to ask because this is not quantitative or qualitative. We did unfortunately not have the ability to ask what our responses were when they identified as two-spirit, and or versus gay or bisexual. That was wholeheartedly up to the participant to indicate what they most identify as. And I can't speak as to why they made the determination and what the difference might be. So I don't want to misspeak on I guess some people from the academic world or interpretation might view that two-spirit could be similar to identifying as gay and or bisexual, but we did not get the nuances as to why what their indication is and what they meant by their preference of choice. So I'm sorry. And
No, don't apologize. I was just curious to ask about that, especially since you were talking about the role of culture in people's health choices. And I just thought that that may have also spilled out into how people identify or the ways that they use cultural archetypes for their identity versus more, contemporary sexual identities, like, and just wondering about that. Thank you.
You're welcome. And then also just thanks for saying that. Just a pin note that not all tribes utilize the word two-spirit. So it's not a universal term
Right.
among and within all tribes. So we definitely included that as an option because some tribes do prefer the term and do prefer to be acknowledged as a two-spirit person. But again, that's not a tribal practice among all tribes.
Thank
So
you.
you're welcome.
Crystal, can I follow on just to, sorry not to belabor this, but it does seem like it might be, maybe there's literature that has, or studies have already tried to probe this, but if not, it seems like a important area for future research, because, does it, is there something more to it, like why some tribes use that terminology, others don't, and within the tribes that do, that some people would identify that way? Is it relevant, I guess, in particular with if you want to address increased awareness of PrEP, do people get offended if you use the wrong term? Or, I guess it'd be interesting to know whether your thoughts about just the salience and kind of resonance of these, how people view themselves and why they may choose one term and another, and does it influence what we collectively as a field should be doing with prevention messaging?
Well, I think that it transcends not just to only sexual orientation, but also tribal identity. I mean, there's so many nuances. So I think just having a general understanding of tribes, understanding that some tribes function as a society as highly matriarchal, and some tribes function as a society as highly patriarchal. And it goes back down to the tribal practices, language, customs, and also systems that where I believe has a deeper embedded context of why or why not some community members prefer to identify as two-spirit and some prefer not to identify as two-spirit. It goes all back down to tribal specific norms of society, of culture, of language, of even the judicial court systems, practices, and so many things. So it's really hard for me to answer that question. It's just about being mindful that each tribe is different, and how we interact with the world is really dependent on that tribal specific, which then leads to identity. And that's the best way I could frame it. Okay, so next slide to the school environment. I would like to give some more demographics that tribal colleges were included in this study, and just the different, most people who complete the survey attend a 4-year institution, and also most were in an undergrad program, and most live off campus versus with a family or with roommates, and or that live alone. So Maria, we'll get back to this. Maria has a point here. she said they will let you know they are two-spirit foremost. They will use both their feminine and masculine spirits to pray to Creator, perform ceremonies, and some tries to honor that two-spirit individuals in high status, because the belief is they are spiritually equipped to stand for their specific people tribe. That was Maria's insight on that. So I think it's different for everyone, but I think that that is a good point from people who may identify as two-spirit, along with a lot of other points. So I just prefer not to say why, because everyone has their own different reasoning, and I don't want to speak on behalf of people's identities. I just honor and acknowledge and thank you, Maria, for that. So we found, I know we're running out of time. I'm just going to quickly go through these slides. There's so much information. I mean, we have 304 surveys, and each survey had 90 questions. So, and also associated sub-questions within the 90 questions. So just some basic sexual health practices that more than half of respondents said they agreed that they're comfortable talking about sex with their families. And also the number of sexual partners commonly used in access, which was all important about health indicators of sexual practice. I think it's important to find is about a third of people indicated that they almost or never were able to get condoms, which I think should play into more of why we do the work that we do. And 37% they could sometimes get them, so which equates they sometimes use them. And then the other third indicated that they could use condoms almost every time or all the time. So just some practices to be mindful of. Also, we did ask about drug and alcohol use prior to sex. Whereas with alcohol use, it was 32% rarely use alcohol prior to sex, or never use alcohol prior to sex, almost half rarely, and 1% was frequent, 18% was occasional prior. Also, about drugs, most never used drugs before sex, but those that did, drug of choice was marijuana at 13%, 10% for other drugs, and 9% for prescription drugs. So now we're moving on to HIV knowledge. Knowledge of HIV. Next slide, please. About 10% of the respondents say they knew a lot about HIV. Half knew about quite a bit. 38%, which is still a large portion, said they knew very little, and 1% said they knew nothing. Those that were likely to know more were younger or male, who identified as straight, and who felt comfortable talking about sex with their family members. Okay, move on to the next slide, please. To knowledge of HIV risk. I'm sorry. Factors associated with greater knowledge of HIV. So those that lived off the reservation knew more. Talking about sex, the comfortability levels of talking about sex with family members is important. Using their school center as a primary source of care. Living off campus compared to those who lived on campus, and living with family or roommates. Well, these were all indicators of their knowledge levels of HIV. Can we go to next slide, please? Knowledge of HIV risk, perceived risk of getting HIV. So ranged anywhere between 5% to 40%, from not sure to almost high risk, moderate, or low. And 88% knew of their HIV status. And then also the sexual health factors that contribute to one's HIV status was believing that one was at moderate or high risk for HIV, and having higher multiple sexual partners was a huge statistical indicator. Sources for healthcare and information, slide please. We did indicate all these places where they preferred treatment of care. And so school clinics, AIHS and or tribal clinics, the VA or other government clinics, urban Indian or other community health-based clinics, and or a private doctor. So again, the respondents, if they had access to their school health clinics, that was more beneficial for them in receiving health care. Not a lot went to a private clinician. And for information, again, student healthcare systems were predominantly sought out with this versus the IHS or tribal clinic. And then all the others were put together with private doctors, community, or traditional healers. So IHS does play a huge part in also dissemination of information and treatment. Knowledge of HIV pills. So more than half, 60% knew that PrEP daily would reduce HIV infection, and that's pre-exposure prophylaxis. Slightly more knew that the daily PrEP pill PrEP pill would reduce the possibilities of HIV infection. And a lot of them were knew how they could access either PEP or PrEP. There's so much data. So I think Marcus could go ahead and distribute the PDF slides because of just how much data about basic knowledge of PrEP and PEP were in this study. We could go to the next slide, please. Those who had more knowledge in PrEP and PEP happened to be younger, knew about their HIV status, have the likelihood of ever having been tested, were more comfortable talking about safe sex, had access to a student health center, knew their positionality of either being at moderate or high risk, a perceived HIV risk, attended a 4-year institution, and or lived with roommates rather than a family or alone. So on to attitudes towards use of HIV medications. Next slide, where cost is a consideration. Majority of our majority said they would be likely to use PEP despite the costs, and also would be likely to use PrEP if they had to still pay half of their PrEP care. And so the cost was important because although people might have access to IHS, we don't know if IHS, those IHS hospitals and or clinics distribute PrEP within those specific locations. So we wanted to know if they were acquiring PrEP or PEP healthcare elsewhere and they had to come out of pocket, what's the likelihood that they would engage in PrEP or PEP use? And then also those that indicate that 20% would not take PEP and 15% would not take PrEP due to cost. So support is highly important. If they had family support, was important about the engagement of use of PEP or PrEP. Also, if they were negatively judged, hence lack of support, indicated of how much less likely they would be able or would want to use PrEP or PEP. Still feeling stigmatized at the IHS or any tribal clinic or any other facility was also important to the decision making about whether to utilize PrEP or PEP. Side effects are a concern. Next slide, please. And just that, how much of a comfort level would they have with serious side effects, with long-term side effects, and also the commitment to take these HIV pills and not miss any pills, and how much that would be a concern for the participants. Next slide, please. Comfort levels, there's definitely a need for more information to be disseminated. The information I think could help produce productivity on addressing the uncomfortableness of taking HIV medications, and also just more information because the concern of the effectiveness of taking PrEP or PEP, and asking a healthcare provider or an entrusted person was also important. Okay, next slide. If we could go to HIV testing. Almost 80% have been tested for HIV, and the frequency of testing are levels from 18% to 51%. Again, the student healthcare was a huge factor on if they get tested or not, followed by IHS or tribal clinic. Next slide, please. About a fourth of persons had taken PrEP at some point in their life. Those that did were more likely to be younger, male, identify as gay, bisexual, two-spirit, and more likely to have a lower cultural affiliation. Next slide, please, with PrEP. I'm trying to rush through this because I know where time is running out. 1 in 5 respondents said that they have taken PrEP at some point in their journey, and there's a 50% about almost of equal distribution. And respondents who identify as gay, bisexual, or two-spirit were 6 times more likely to have taken PrEP. Respondents who identified as straight were more likely to take PrEP with casual partners. So the age plays a difference, and also cultural affiliation. So those who their cultural affiliation was negatively and significantly associated with having taken PrEP. Those with the higher cultural affiliation score were more likely to take PrEP if they were in a relationship with an HIV partner, or if they engaged with casual sexual partners. So again, cultural affiliation plays an important part of their PrEP use and previous or current use. Factors of affecting HIV behaviors. Next slide, please. Respondents asked if they thought people at IHS or tribal clinics would stigmatize them, and many of them thought that likely it could happen, 39 to 46%, and only 15% thought it was not likely that an IHS or tribally run clinic would stigmatize them. So still have to work with our native health clinics to reduce the perception of stigmatization in order for our population to receive comfortable care within their tribal clinics. Again, support plays a huge role within their family and friends of them affecting HIV behaviors and the use of PrEP or PEP. So on to pathways forward. Native youth do want trustworthy information. And I think that I also think that social media could help reduce a lot of the stigma, and try to work with other student health centers or IHS and or tribally run clinics. In terms of working, I'm sorry, I worded that wrong. I think more needs to be done to work with our student health centers, our Indian Health Service as entrusted points of information, where because social media is not a place to obtain information that they felt were mostly trustworthy. So that is interesting to know that Native college students do not trust social media when it comes to some points of their healthcare. Native youth want options for care. We did input options and how they would feel most comfortable with different options versus walk-in only. So even with an app, not likely to use it, about half. With telehealth HIV tests, which is interesting, about 70% of persons say that they would feel comfortable. And only 4.6% said they would not feel comfortable with the telehealth HIV test. The comfortability of using telehealth for a PrEP program for testing at home, more than half were comfortable with this, and about a third were somewhat comfortable. And this includes, because I know with engaging in a PrEP program, you do have to test for things such as liver function and kidney function, that they would be comfortable with doing those at-home tests to send into the labs. And also the comfort of using IHS, of obtaining PEP after every exposure. About a little less than half slightly agreed or slightly disagreed. I think she meant to say agreed. Sorry, there was a. And then also the comfort of using IHS to get PrEP every 3 to 6 months, with almost half being mostly comfortable with it. Okay, so conclusions. So much to go through. There's still so much data that this is just the tip of the iceberg that we put on to give a scope. That I mean, there's so much data from the study that we could go more precise into different angles. But in a nutshell, that more information, obviously more research needs to be conducted, because this was a very baseline study on knowledge and attitudes and behaviors of testing, of preventative methods of PrEP and PEP, and comfortability levels, knowledge and information. But we definitely still need to work on reducing stigma, increasing support, opening up different avenues of ways of communication and access, and also, again, improve access to prevention and treatment options. So student health centers are at the forefront. IHS can do more, and peer-to-peer information is important to this population, and peer-to-peer support as well. Okay,